Welcome to this night's living room from Chicago. My name is Kim Parham, and on behalf of the Bonnie Dario Lung Cancer Foundation, I would like to welcome you in the room, our panelists, and everyone online. Danielle and Bonnie are not able to be with us, so it's Michelle and I here tonight with all of you all. And thank you for coming out on this cold night here in Chicago. And it is the start of November, Lung Cancer Awareness Month, and we're having a really good campaign recognizing thrivers and survivors this month. So please log in, share stories, read stories, and get inspired. And before we get to our panelists, we wanted to just go around the room and everyone just introduce yourself if you feel like talking, and say a little bit about your lung cancer, when you were diagnosed, if you would like to share, what stage, and anything you might want to learn from the panelists and from each other. Yeah.
Okay. Hi. My name is Jill Feldman, and I am a lung cancer patient and advocate. I was diagnosed originally in 2009, and I was originally stage 1, but then I had several recurrences, and I've had surgery and radiation, and I've been on targeted therapy, and I'm doing great today. And I'm happy to be here.
Thank you. Pass it on.
Hi, I'm Ivy Elkins, and I was diagnosed in December of 2013, so I am coming up on my 5-year cancerversary in December. I was diagnosed stage 4 lung cancer, EGFR positive. I've been on 2 targeted therapies. The first one lasted for the first 3 years, almost 3 years of my treatment. The second one I'm still on today, going on 2 years. And that I'm here because this is my cancer center, and I love all the people up here, and I just want to come and hear what they have to say.
Hi, I'm Kim. I was diagnosed 3 years ago, EGFR exon 19, afatinib for about 1.5 years, with a little Tarceva at the end, and then was on Tagrisso. I'm now have the C797S mutation, so I've been doing chemotherapy, carbo Amita Avastin for treatments, then Amita Avastin maintenance, and we added Tagrisso back in due to some brain lesions that had popped up. And I was lucky to have Dr. Patel as my oncologist from the very beginning. So of course we're here to cheer her on and see and hear what is going on in the cancer research today.
My name is Clara Lambert, and I am not a patient. I'm an oncology financial navigator and a big fan of the Bonnie J. Dario Foundation, so I come see them whenever I can.
I am also not a patient. My name is Carol Knopp, and I'm an oncology nurse who works for one of the sponsors of Bonnie Dario, Boehringer Ingelheim.
My name is Dawn Paulson, and I am a patient. I have EGFR, but I was first diagnosed 14 months ago, and they first thought I was stage 1, and then I had surgery, and they decided I was stage 3A. So then I had 6 weeks of chemo and radiation, and then 3 infusions of durvalumab. And then I ended up with a lot of bone mets and brain mets. So then I was on afatinib for 3 months, and then they finally decided that they'd put me on Tagrisso, and the brain mets are all gone, so that's great. And I just changed from one oncologist to another, and I'm now a patient of Dr. Patel's, and I am so glad I am here.
Yay!
I'm Dave Paulson, and I'm Dawn's caregiver.
Yay. Would you like to share?
Yes, ma'am.
Okay, thank you.
I'm sorry I'm late.
That's
I
okay.
couldn't find this place. 2 hours I'm around here looking for it, but anyway, I'm here, thank God.
Yeah.
My name is Iris Brown. In 2016, I was diagnosed with breast cancer in stage 4. It had spread it to my lungs, and now it's up in my neck from all the stress I had where I live at, and to my bones, and I hurt every day. Dr. Hoffman is my doctor at the University of Chicago. And I thank God for the University of Chicago, because they've been really good to me, and they really helping me to live. And I thank the Lord why I'm still here. So I just wanted to share that with you. Oh, it's also in my lungs, too. That's why I came here, to try to get more information, because I do not smoke and I don't drink anything like that. And I wanted more information how I could take care of myself, you know. But where I live at, those people smoke. And they got it all in their clothes, and they smoke in their rooms, and they get all in the hallway. And I end up having a breathing condition, because I have COP. I was born with asthma, and I have COPD, and now the lung cancer. So I really, y'all just keep me in your prayers. And I thank the Lord how he's working on me. And I thank God, like I said, for the University of Chicago. Thank you.
Thank you. And now I'm going to let the panelists introduce themselves. And the topic today is on treating lung cancer today.
So I'm Jessica Donington. I'm the new chief of thoracic surgery at the University of Chicago. Obviously, I'm a surgeon. I treat a lot of people with early stage disease. But the extent of surgical resection is reaching further and further out into all stages of lung cancer. And what's going on mostly that's hot and new today that we can talk about a little bit are just smaller and smaller incisions, less invasive surgery, trying to make surgery part of multidisciplinary care. It's not just that you get one type of treatment, but you're going to get all kinds of treatment.
My name is Kyle Hogarth. I'm a pulmonologist and a bronchoscopist. I'm fortunate enough to have colleagues who I work closely with in the field of bronchoscopy and pulmonary, obviously focused on lung cancer, both with early detection with our lung cancer screening program, and then also early diagnosis in regards to the ability to biopsy small nodules, and then appropriately stage patients if that's also necessary with minimally invasive techniques. And I'm fortunate enough to also be working with the people you see up here on the stage, and amongst many others who are not here. You know, if ever there's a disease that requires a team, it's definitively this one. And so I'm glad to be here.
I'm Josie Patel. I'm the director of thoracic oncology at the University of Chicago, and I'm thrilled for you to be here and to talk a little bit about why I do this and what's really exciting and what I'm most excited about in the next decades. It has been a dizzying time in lung cancer. Certainly I never thought that I would be a lung cancer oncologist when I started medical school, but I very quickly got hooked on the science and discovery, and very quickly realized in the first phase 1 patient I met, which at the time phase 1 meant early drugs that were unlikely to work and given to patients who had exhausted treatment options. It was a different paradigm back then. But I was in clinic with a wonderful oncologist, Mark Chris, and we were treating a patient who'd undergone multiple treatments, and he was like, we're going to try this pill. And I was like, this pill? This drug, gefitinib or Iressa, and this woman, even though she'd had multiple therapies and was profoundly symptomatic, had disease response within days. And at that moment, sort of seeing where the science could go and really seeing the impact we could have on patients, became clear that I was going to become a thoracic oncologist. And that's really the beginning of what has been almost 2 decades of constant progress. It's amazing to think about how we approach lung cancer now. Almost every patient I meet with advanced disease is treated differently than I would have treated them 5 or 6 years ago. It's a tremendous pace of discovery. There's much work to be done, but it's really something that is done in partnership with great teams. Because patients have multiple needs, because we're learning more about how to get information about the patient and tumors, it's a team sport, and it requires good communication. It requires sort of that 360 view of not only what's happening in front of us, but the idea of what could happen and when do we push and when do we think about decreasing certain interventions to decrease toxicities and to improve quality of life. And there are other times when we're sort of all in, asking for things that would have sounded dramatic a decade ago, like resection or higher doses of radiation or more tissue to understand fundamental questions. So thank you.
My name is Livia. I am one of the 4 nurses in chest oncology. The other 2 colleagues won't be able, not able to be joining us here. So I've been an oncology nurse since '87. So I started off with working inpatient hem-onc floor, working with head and neck cancer patient from '87 to '97. I joined the lung cancer group because my older one started kindergarten and I worked 12-hour shift. He said, "I'm never home," so I quit my job and I went to interview in infusion center, and Dr. Hoffman and Sylvia Watson kind of detoured me my interview. So they both were saying that you are not going to work in over infusion center. We need a nurse in the lung cancer group, and that's how I joined them, and ever since '97. And I was really devastated when I had to leave the head and neck patient populations. I thought that was my love, and then shortly after I joined the lung cancer team, I think that I found my passion. I think lung cancer is my passion. It's definitely. I would never change anything else.
Michelle, anybody online that has anything to say or add?
Someone actually is asking for an explanation of something.
What?
They would like to know for someone to clarify what EGFR is.
Okay.
That's a good question. We have a lot of EGFR representatives here.
So we used to talk about lung cancer in sort of a monolithic term that we'd say of the 200,000 people in the United States that had lung cancer, all of them were sort of had lung cancer, and it was either small cell or non-small cell based on what it looked like under the microscope. We now understand that people have distinct kinds of lung cancer based on the genetic profile of the tumor. And it means essentially not that generally not that you've inherited a mutation, but that your cancer has acquired a mutation that's causing the cancer to grow. EGFR stands for epithelial growth factor receptor. And it is a well-documented mutation that happens in about 10 to 15% of Americans and higher numbers of Asians, higher numbers of never smokers with lung cancer. But it's a mutation that essentially is a single change in read on a chromosome, that a single base pair causes a protein to turn on, and that protein sort of stays on almost like a foot on an accelerator. It's a proto-oncogene. It causes that cancer to grow. And because it stays on, it causes growth signals that cause cancers to invade and multiply and to not die appropriately. And so that is one of our biggest targets for lung cancer. It's a particular mutation called EGFR. We've learned in recent years that there are a multitude of mutations. And so now we know that if we look at a tumor, we go beyond just looking at what it looks like under the microscope and really understand the genetics behind the tumor and do genetic testing, which might show an EGFR mutation, a MET exon 14 mutation, a BRAF mutation, a HER2 mutation, translocations, which are flip-flops of chromosomes causing proteins or genes to fuse together to form proteins that cause cancer growth. there are a huge number, and that list is always growing, of potential mechanisms why the cancer grows.
Well, it's a lot. Yeah. And there's several EGFRs here in the audience, and you all just pipe up. I'll take you the mic if you have questions. We're here for you.
For the person who asked the question, I mean, besides wanting to know what EGFR is, this is actually unbelievably important because there are multiple ways to test for this, and there's still sadly a lot of people who get diagnosed with lung cancer, and the targeted testing and then the targeted therapies that Dr. Patel is talking about are not being offered to these patients if they're not at a place that's up to date. And so I think of this mutation profile as the same way that you would describe someone's height, weight, sex, hair color, eye color, because everyone's tumor is different, just like every person is different. And if you don't look at those differences, then you get a one-size-fits-all. And I've never had a one-size-fits-all thing ever fit me. And so, for obvious reasons. And so when you try one-size-fits-all chemo, you get a one-size-fits-all response. And that's been the wonderful thing that's been going on in lung cancer. Every time I open a journal, even a pulmonary journal, there's another article about something brand new and exciting that she's doing, and it's incredible. And so every day we're spending more time getting more tissue to go explore for what's brand new today that wasn't there yesterday.
Let's back that up to early detection now. So who can qualify for screening, and how are you detecting cancer earlier to have the genomic testing appropriate and possible surgery, radiation? Just kind of walk us through how that would happen.
Why don't you fire it off?
So I'll start with screening. So the first trial that finally found a benefit to CT screening for lung cancer just came out about 5 years ago. I don't want to say it was ignored. It wasn't ignored. It's been slowly adopted and slowly integrated. And it showed that if we took high-risk individuals, which may not have been any of you in the room, unfortunately, but people who are over the age of 55, who had smoked for more than 30 years, who had quit relatively recently if you weren't still smoking, that those patients, if they underwent a CT scan once and then possibly yearly, had a decreased risk of dying from lung cancer. That was a great trial. It was one here in the United States. It took like 20 years to do it, and it was the National Lung Screening Trial. This past year, the second positive trial came out when we were all in Toronto at the World Conference for Lung Cancer. It was run in the Netherlands. It was called the Nelson Trial, and it showed even a greater reduction in deaths from lung cancer related to CT screening. So we are kind of at this point where this is becoming an imperative in our country to make CT screening for lung cancer exactly like mammography and colonoscopy and a yearly PSA. It's just something we have to do in those individuals who smoke. It doesn't mean we shouldn't be looking for that next detection technique that will help find it for everybody, but in those high-risk populations, this is really essential. And it's essential that we have patients asking, or not even patients yet, having individuals who have smoked asking and talking to their doctors about this. It's really important.
Yeah. What do you think about, where do things stand with screening for people who have an extensive family history of the disease?
That's always been really hard because we know that there is a genetic link to lung cancer. For a while it was really hard to tease out like the genetics of lung cancer from people who smoke in packs, but there's clearly, a genetic basis to lung cancer. I think it's going to be a while before we can convince insurance companies to pay for that. At the same time, do I not think that this is still, if you have a family history of lung cancer, something you could discuss with your doctors? I absolutely think it is. Because I know that there are people who don't quite fit in the box of what is currently recommended by our government for who should be screened, but who should still be having that active conversation with their physicians.
Yeah, the American College of Chest Physicians guidelines on lung cancer screening, and there's multiple different recommendations that are all within the U.S. pretty similar with subtle differences. But one of the caveats they put out recently was to try to address questions like that and said, though there's not strong enough evidence to say this is a general recommendation, Clearly, in the end, all guidelines are just that. They are guidance. They are a starting point, but an individual's discussion with their physician and the pro-cons to obtaining CT screening should always be entertained and should always be discussed. You know, there can be obviously financial ramifications for ordering a CT scan that's not going to be covered by an insurance company. It can be a very significant out-of-pocket cost for an individual. There are ways to help fight that, but it's the eternal struggle sometimes.
And I'd add that I think things are changing quickly. So
Yes.
as we're getting more germline information, so that means in not cancerous genetic information, but inherited genetic information, we're starting to understand susceptibility. We'll be cataloging this over time. And so what we know today necessarily is not going to apply in 10 years. Our technology for CT scanning is improving significantly. The dose of radiation, which was always our worry in young and healthy individuals, continues to decrease phenomenally. We have better predictors based on radiomics about what a cancer could look like, because that's really the issue, is we don't want a bunch of false positives or CT scans that look suspicious, in which we do invasive testing, which could hurt someone, and that's why we don't do CT scanning more frequently. But so that there's a learning curve, and we're getting there, but it really does take attention to collecting tissue, collecting blood from healthy volunteers. And so that's a big effort in Chicago. The All of Us initiative, I think, is really looking at a diverse group of individuals to provide serial biologic specimens and to follow for interceding illness and disease.
Okay. So if you have a CT screening or an image possibly done as a pre-op or gallbladder and they see a nodule, how do you determine the appropriate surveillance of those nodules? What helps guide you?
So similar to what we've talked about before, there now are guidelines that allow us to look at a nodule and then also look at the individual it's in, look at the risk for, you know, how likely is this to be a cancer based on the individual, and then what does the nodule look like. And that guides us as to who needs a biopsy, who needs to be re-imaged in a couple weeks versus who needs to be re-imaged in a couple months, or who needs to be re-imaged in a year, or maybe never. I always tell my patients now that, you know, we have such good CT scans, we see everything in people's lungs, and as we get older, our lungs are like our skin. They're not perfect anymore. There are freckles, there are moles, there are wrinkles, there's all these things, and luckily we have really good chest radiologists who are good at kind of reading that map and letting us know which ones need attention and which don't.
Yeah, the approach to a nodule is are there things about it that make me more worried it's cancerous or a lot less worried it's cancerous? And that's what helps then guide the recommendation to watch and wait and following some of the guidelines on that. Because and it starts with size. Larger the nodule, the more concerning it is. Also shape and characteristics of it. And all these are part of the radiology. And so things that are less worrisome from a cancer perspective, notice we don't say zero risk, but those are the things that what we're trying desperately to do is to avoid unnecessary invasive procedures, because each of those carry a risk. And so something is potentially low risk, we're going to offer a repeat imaging to see if there's been any change in characteristics of the nodule, to help try to avoid unnecessary bronchoscopies and surgeries and needle biopsies, etc. But paying attention to the follow-up, because if it changes, it still doesn't necessarily mean it's cancer, but now the risk has gone up. And now the risk of any form of an invasive procedure is worth it, because now we need to know the nodule has shifted.
So if it is changing and you're getting suspicious, then how do you determine how to retrieve tissue? And talk about all the different
At least
options.
one of the two of us.
Both of you all. And the new technology that is available today.
Yeah. So depending upon your level of suspicion and what else you might need to do in terms of treatment would determine whether you might start with a surgeon versus starting with a pulmonologist or an interventional radiologist. For many small nodules, we want to know before we would really commit someone to an operation. So you might start with a pulmonologist, and we have really exciting technology now to help biopsy smaller and smaller nodules within the lung at almost any location in the lung. You want to tell them about your cool robot?
Sure. So, you know, there's whenever there's a nodule, and I agree completely with Dr. Donington, there are certain scenarios where the probability when you look at the nodule that it's so high that it's cancerous that you can have a discussion with the patient that, you know, my opinion to you is that we should just go simply cut this out, because though there's a chance it won't be, that's small enough, and even if I prove it's malignant, it looks early stage, we should talk about going straight to surgery. Let's bypass an unnecessary procedure. But for a majority of nodules, that doesn't come up as often. For a majority of nodules, there's still a debate. And if a person doesn't need to have part of their lung removed, especially depending on their lung function, because a lot of people come to us and have significant lung disease, and so a thoracic surgery is a big deal for them. And in the hands of an expert, it's less of a big deal, but if she doesn't need to operate, that's clearly better for the patient. And so that's where bronchoscopy comes in. The advantage to bronchoscopy is at least the ability to not only diagnose the nodule, and if it is malignant, but during the same procedure, then sample all the lymph nodes and determine what stage you're at. One of the most frustrating things that I confront, and I know they do as well, is people that present with some form of a mass, nodule, etc., that underwent a needle biopsy, a very standard procedure, unfortunately proved it was cancerous, but we have no idea what stage you are. We've not sampled a single lymph node. And some will say, well, I had a PET scan. And I wish PET scans were as good as we all hoped they were, but the literature is unfortunately full of the detail that PET scan's probably accurate about 80+% of the time. That's not good enough. Not when I'm going to tell you you're stage 1, but in reality you're stage 3. Because when I treat you as a stage 1 and you actually are stage 3, I know you're not going to do well. And so until I prove that your lymph nodes don't contain tumor, that indeed that nodule was cancer, but all your lymph nodes are negative, and we can do that in one anesthesia event, so one procedure, then now we know you have cancer, but we know it's early stage. Now you're going to go get cured. And Dr. Donington is going to take care of you. And it's fantastic. Now you know why you're going to have a surgery and what it's going to do for you. And if we discover that any of the lymph nodes do have cancer, depending on ultimately what stage, etc., well, there's clearly going to be a role for chemotherapy and things like that. Dr. Patel's got a lot of tricks up her sleeve for you as well. And then depending on the stage, well, we're still going to have you visit Dr. Donington. And so there's so many options here. And I think that's, again, comes back to this coordinated team. When you sort of fly solo, you know, the problem when you work in a silo, right? It's the oldest joke in the world. You go to the barbershop. Who comes home without a haircut, right? So if you go to see one person who does one procedure, that's the procedure you're getting. Well, I don't bronch everybody. I don't do bronchoscopy on everybody. Plenty of people I see go straight to her because it's not important. Now, you asked my little new toy. We are fortunate enough at the University of Chicago to have a piece of technology that is definitely changing what we can do inside the lung. Mm-hmm. It's a robotic endoscope. It provides an unprecedented level of ability to see and stability so things don't move, and reach to get out to parts of the lung that we've never been able to get to before. And the advantage of that, of course, is the ability to try to biopsy things, improve what's going on, or go get more tissue if there's a new study and we need more tissue for a new drug. And probably the most exciting thing that's going under investigation right now, there's a center doing it, a friend of mine's running the trial, and we're going to be part of it soon too, is the ability to do ablative therapy. So if I can slide my little robot catheter out to the tumor and prove it's a tumor, and for many myriad reasons, maybe you're not a surgical candidate or whatever, well, or you've maxed out on radiation, we can't radiate you more, why don't I put a microwave catheter in the middle of it and nuke it from the inside? We're already there. Now this is something under investigation, but the ability to get to new spots opens up opportunity. Maybe the ablation device won't work. It won't work the way we're hoping. Only one way to find out. But now that we can get there, we can actually ask that question and bring another tool to the entire toolbox that we have between chemotherapy, surgery, radiation oncology, and then now ablative therapies.
With this tool, thanks. I know with a traditional bronchoscopy, you can't get to all areas of the lung to look at nodules. So with this tool, what percentage of the lung do you think you can cover in order to get to nodules?
So myself and then the 2 colleagues of mine around the country that have this device so far, and then there's plenty others that are about to be shipped out, kind of bluntly, we haven't found a spot we can't get to yet.
Wow.
Yeah, it's so to do what I do, and it's probably very similar for a surgeon, to always have known there were spots that you were limited by, that you have a patient that you really want to help, and you had nothing to help them with. You just, I know I can't get to this. And so I'd have to send them off saying, I'm sorry. I know that I won't be able to help you. To have that barrier removed, it probably feels very similar to what Dr. Patel's gone through in the sense of where she has now all these amazing new things that she can do for people, where historically it was like, well, I have this and this. And now she's got a toolbox full of things. It's incredible. And we all do this because all we want to do is help people. I mean, that's why we're in this business. And so to be able to not have to turn people away is really neat. Right? I mean.
One of the things that we're also looking at and is kind of exciting, not only for tissue acquisition and microwave ablation and thermal ablation, is intratumoral ablation. So a number of clinical trials, particularly with immunotherapies, in which we deliver drug right into the lymph nodes or into the tumor itself. And right now we're doing sort of ones that you can feel, like a lymph node or a palpable mass. But our hope is, again, to be able to deliver the drug or the vector, which might be an RNA vector, which causes a tumor to sort of get inflamed, directly into the lungs. So that's an area, again, now that we have these tools, might open lots of therapeutic opportunities.
And you said there's only 2 other places in the country that have the same toy that you
Yes, at the moment.
Don't tell the CEO it's a toy.
It's okay, it's a toy.
The advanced technology that is very helpful.
Extremely expensive, incredible, amazing technology. At the moment, yes. Others have been purchased, and that's the company's business.
Okay,
but,
I mean, I'm just thinking of people who are all over, kind of the country that it will be available at more.
I'm sure the company's plan is total world domination, but until that day, there's still some
You may have a
limits.
lot of people flying in other
Well, what I will say is this, and from the pulmonologist perspective, as a bronchoscopist, but and clearly biased working at the University of Chicago, but there are around the country clearly some great places for surgery and oncology and pulmonary. But if you're not at one of them, get in your car and go to one nearby. If you're having your surgery by a non-thoracic surgeon, and a lot of chest surgeries are, I'm going to say this so it doesn't look biased, a lot of surgeries on the chest are not being done by a thoracic surgeon. They're being done by a heart surgeon, who's an amazing heart surgeon, but they don't touch lungs. Or worse, a general surgeon, someone who's below the diaphragm. You might as well have me do it. And so you want a thoracic surgeon doing your thoracic surgery.
So I can't thank him enough. He's my PR guy. I give him a little bit on the side.
Well, no, there's data on this, though, right?
There's really, there is impressive data that shows survivals are better. Not even, it's short-term survival, so the people who survive the operation, they do it with fewer complications, shorter time in the hospital, quicker return to work. Oh my God, adjuvant chemotherapy, it's like night and day, who gets it and who doesn't. Yep. And then long-term survival. So,
and I'm sure long-term side effects.
Long-term side effects. And then the percentage of patients who get their, resections done minimally invasive, with a VATS or a robotic versus having them done through thoracotomies. It breaks my heart when I see people who get, transferred to us for complications or something, and you kind of roll them over and there's that giant incision. You're like, oh my goodness, I haven't done that in years, and it just breaks your heart because, that's what we did 10 years ago, and it hurt. It was horrible. It was so hard. And sometimes we still do it for really big tumors and really difficult cases. it's worth it to take out, anything to get all the tumor out. But for small tumors, it just makes such a big difference to have it done minimally invasively. And I've taken a pretty big stand nationally in saying that, patients, primary care doctors, pulmonologists, medical oncologists need to seek out good thoracic surgery. If we're going to improve the cure rates for early stage disease, that's part of it.
But you have to actually be staged.
Yeah, you do have to be adequately staged.
Everyone's 1A until you look at lymph nodes. Right. And when you look at lymph nodes, you prove that people aren't 1A. And then going for a 1A curative resection, which was never going to work because you weren't 1A. And so till you look, and so if you've not been staged, so the people online, if you've not had a proper staging, a PET scan is not a proper staging.
So can I ask, you were stage 1 before your surgery, right?
I did not have a, oh, I'm sorry. Oh, you don't want to get me started.
Oh, goodness.
Ask Dr. Patel, you don't want to get me started.
Yes, I would be willing to bet, unfortunately, you were not staged.
No, well, I had a PET scan. I was incorrectly staged, and I went to a hospital, a lung cancer oncologist associated with a hospital. I won't say why.
Yeah.
Anyway, what they did was on the SUV rating on the PET scan showed that the tumor, which was 1.4 centimeters, was pretty small, but I had 3 lymph nodes that lit up on the PET scan, but not real high.
Oh.
So they thought it was probably a fungus.
Wow.
So then they sent me to the thoracic surgeon who went in, but when he checked the tissue on the lymph nodes, there was cancer there. So he just sewed me back up.
Oh, goodness.
Well, he didn't take out the tumor. Of course, I don't know, I wasn't very happy when I came to, but then what they explained was they were going to use chemo and radiation. I was now 3A, and they were going to use chemo and radiation, and they were going to use the tumor like the canary in the cave. So if the chemo and radiation took care of the tumor and shrunk it, it would show it was working. And so I did my research. I'm actually a professor at a university. I have a doctorate. So I did research, and when I'm looking at stage 3A, this is what it showed. But I did not have a bronchoscopy, and I'm like anybody else. When you get this diagnosis, I've never smoked in my life. A cigarette has never touched my lips. And I'm like, oh my gosh, get it out, I want it out of here. And so, my husband took good care of me, but I had 30 days of radiation then to the lung and the mediastinal area. And actually then 3 weeks later, I had a CT scan and it had shrunk. Now, the Pacifica trial had just ended, and so they did durvalumab. I had 3 infusions. Yeah. Now, the problem here was, in the meantime, I'm checking and I'm learning about liquid biopsies and what about a mutation. And I found research, my poor husband said, don't get into it, that showed I knew I was everything but Asian and I had EGFR. And he wouldn't test my tissue that they took. And I just couldn't figure it out. And then in January, I had progression of disease. And I ended up with brain mets and bone mets. And so... Anyway, I kept having, we would go, I want my tissue tested. Well, he did a liquid biopsy. But anyway, it wasn't until April he tested my tissue. And then he said they tested for, the liquid biopsy said I had HER2 and EGFR. But now I'm on the EGFR resistors page. And I met some people at HER2. And I private messaged them and I called them. And the HER2 came after the EGFR, not at the same time. And I would tell him that. Anyway, so one time he told me to get off the internet. And I go, I'm reading research. I'm not reading what grandma said about cancer. I'm reading the research. And I said, now I had afatinib, but I didn't do well on afatinib. I mean, I got sick and all, and then I had progression. So I said, I want Tagrisso. And he wouldn't give me Tagrisso. So finally, and wanted me to have whole brain radiation. I said no. And he didn't like any of that. And I said, I want to try Tagrisso. I think EGFR is my driver mutation. And so finally, he tested my tissue, and then he said it checked for the wrong HER2. I don't know about that. And then he checked it again 3 weeks later, and he said, you can have EGFR. And in 30 days, my brain mets were gone.
Wow.
And I changed to Dr. Patel.
Wow.
Yeah, I talked to Ivy and private
so
messages.
much, like, yeah, your case is amazing. I wish you were not the only one who we've heard all of this, and it does. It really emphasizes the importance of good staging before your procedure. I mean, it would have saved you a trip to the operating room with a thoracic surgeon. You still were going to need your chemo and radiation, but I mean, at some point, right, knowing what your mutation was would have made a big difference.
And we can get the mutation analysis from the material removed from bronchoscopy. It does not require an entire tumor. It requires a very small amount, and that's what bronchoscopy can yield.
And he used the tissue from in September I had the surgery, and that's the tissue he used in April to check for EGFR. So he could have used it in September and checked for EGFR. It wasn't new tissue. I never had any other tissue checked.
Right, and you know, there was a time when we all thought that we could look at a person and know what mutation they had. And we've learned that that doesn't work at all. That, you know, your tumor is individual, and just because you're not Asian or just because you may have smoked doesn't mean that you can't have EGFR.
Or not female.
Or not female. So yeah, I think we test everybody because it's amazing what you find.
So certainly testing has tremendous implications for all treatment, but there are a lot of issues, I think, with stewardship of tissue and how patients are disclosed information and how we disclose it to each other. And that is one of the reasons where I think multidisciplinary care is so important, as to really have everyone within an institution or whatever your care network is aligned with how tissue is going to happen. So at our institution, what we've been able to put into place is reflex testing, and more institutions are doing that. And that means that as soon as Dr. Hogarth diagnoses lung cancer, it automatically, there's an institutional pathway by which testing for immunotherapy as well as for mutations occurs. And if that doesn't happen, if he ever leaves and goes on vacation, then it would go into his box. He would come back 2 weeks later and then catch up with all of these results because he might not have acted on it. That result would then say, initiate testing. Testing would take 2 more weeks. Right. There are multiple ways to drop it and cause delays. By having sort of institutionalized our testing pathway, it's really reduced delays and made us much more cognizant of where tissue goes. It's a precious resource, right? It's a gateway to clinical trials. It's a way that, again, just in clinical practice will help you decide what to do with your tissue, and so parsing out just how much we need for a particular test, which is a smaller and smaller amount now for next generation sequence testing, but is still considerable. To have some in the store for, in storage for subsequent studies is all important, but it needs a coordinated effort with pathologists, with interventionalists, whether it's surgeons, interventional radiologists, or pulmonologists, and medical oncology sort of shepherding this through.
Right, and it's important that they know that from the minute the biopsy's done, so that if they do the biopsy, you have to have the pathologist in the room with your bronchoscopist, so that once they know that it is cancer, do you have enough? Do you need more? While we're here, we're not leaving the room until everything we need and that everything you'll need for the rest of your treatment has been obtained.
One of the things that we're fortunate to have is a pathologist right there in the room guiding us to both provide a diagnosis, but also to say that there is plenty of tissue here. And our general rule, at least in bronchoscopy, is once the pathologist says, I have enough, we take 4 more passes because
usually calling you for more.
Right, because inevitably someone's going to want more. So we try to get more right up front. But I will also say the other advantage is as the ability to acquire tissues become less and less invasive. The work I do is always outpatient. You go home afterwards. It's a half an hour to an hour and a half procedure, sometimes even less. So if we're diagnosed 2 years ago, 3 years ago, and now you've had a recurrence or a progression or whatever word you want to use, there's whatever was diagnosed 2 to 3 years ago, there's been a lot of changes then. And so let's reanalyze your tumor. Well, if you've got a lymph node there, that's a slam dunk easy thing for us to go and acquire more tissue and give her whatever she needs to figure out how to help you. And including several trials that I know I've been working with Livia on, where we're judging responses to your chemo by reassessing your tumor.
I think that's one of the biggest things that we certainly feel for patients is you have a diagnosis and then we're waiting for testing and we're waiting. And I would think that that's one of the most challenging times, right?
I think that we usually receive phone call from patients that just got diagnosed, totally in panic mode. They want to get started with therapy right away. And then so many times that I said, okay, what did they tell you? Did they say like adenocarcinoma or squamous cell or small cell? What is this? I don't know. I just have lung cancer and I need to get started with therapy right away. No, you don't. Take a step back unless it's small cell. So if it's adenocarcinoma, so we usually want to make sure that did your physician send it for testing? And they have absolutely no idea. So, I mean, you were saying that, like Don was saying, that if a physician's having like such a resistance sending tissue for testing, imagine the patients and the family. They want to get started like yesterday. So many times the patient will start one dose of therapy and come to see us like, what, you already started? We have no molecular panel, like profile. So it is very hard. I mean, I think from a patient perspective, I'm sure all of you guys can echo that. The minute you have a diagnosis of lung cancer, you want to get started with therapy. Waiting for 3 weeks for result is a long time. So it takes a lot of like calming for our patients, but at the same time, it takes a lot of education for the public as well.
That idea of that, yes, there are instances in which getting to treatment is certainly emergent, but for most people, I would say it's more of an emotional emergency than a medical emergency. If you're talking to your physician and making sure that symptoms are stable, getting the right answer is paramount, right? So getting all the available options and doing the requisite testing. It's tough now because in many ways some of our advances have made immunotherapy and chemotherapy available to a huge number of patients, and yes, it's exciting and it really benefits some patients, but not everyone. And understanding who would benefit from a combination of chemoimmunotherapy versus an oral agent or just immunotherapy takes some effort. And it's, I think it's tough on both ends. It's tough being us, and all we want to do is help you feel better, but it's much harder, I think, being a patient and a family member or caretaker who's sort of watching someone in this time of limbo, waiting for answers to fall into place and a roadmap to help them move forward.
Talk to us about who all should be on your multidisciplinary team. How often do you meet? Who all is in the room? And their roles.
I think this is only half, like this is what, a tenth of the group. So we usually have, like every Wednesday morning, we usually have approximately like 25 to 30 people. So thoracic surgery team, like a surgeon, thoracic PA, and pulmonary medicine, they have their physicians, fellow, nurses, NP. And the pathology team, they have their pathologists and their fellows and radiologists. They have like the attending and the resident. And then our medical oncology team, physicians, fellows, nurses, and data manager and data coordinator. So it's a huge, and radiation oncology, I'm so sorry, they will be so mad at us. Yes. So they're good too, so it's approximately usually like 4 to 5 of them. So it is a huge group. And recently we've been having a very short of chairs, and we are like stand room only. So we will be having that tomorrow morning. So yeah.
For the people that are online, if your lung cancer diagnosis is not being managed at a place that has a multidisciplinary tumor board that doesn't meet regular, then pack your bags and go someplace else. Because think about this. Why in the world would you individually go see each of us? That's already going to take too long on your cancer journey. When through a meeting where all of us are present, we can right up front determine that, okay, testing and biopsies and everything, and fortunately proven stage 4. Well, you don't need to come see me or her. Go straight to medical oncology. So, and it's amazing how often this happens. Well, people will get sent to me, or I know happens to thoracic surgery all the time. Someone who will not benefit from thoracic surgery arrives in her office. Well, now we've just wasted some time. Now, luckily at our place, we'll quickly get you right where you belong, but that's all taken care of when you have all the people that are interested in your outcome in one room at the same time. Even people that you've never met, because they're weighing in. The radiologist who you've never met is the one who's reading your scan and comparing it to before and helping to determine whether things have improved or not. That's going to help guide other management decisions. Maybe they do need more tissue. Oh, look how much things have shrunk. It's time for surgery now, you know, et cetera. Now you're getting the advantage of all these brilliant minds in one room at the same time, only focused on you.
And I think it's actually fewer and fewer patients who need one of us.
Right.
You know,
right.
Systemic therapies are moving earlier and earlier because cure rates for stage 1 are not 100%. Right. So clearly we need more chemo or radiation kind of to go along with surgery. And then local therapies, radiation and surgery are moving into later stage diseases as we have, you know, chemos and immunotherapies that work so well. We now have people who have had one little nodule for 5 years. Let's get rid of it. So I think, yeah, and the continuous and never-ending need for tissue is you know, drives this all back to that group too. So I do agree that you really need to be part of a group because it takes a village now. It really does.
So I think there are two parts to it. One, I think what we described was the mythical tumor board. So tumor board means all of us sitting around a table, going through cases, looking at the images, talking about approach to it and pathology. In addition to that, we have a couple of other meetings that I think are important. One is all of us come together for a research meeting. So we present to each other. Like when the new toy shows up, we all want to hear about it. When there's a new clinical trial that we're starting, when there's a new intervention, we present to each other and keep each other informed. So that's an event that happens frequently. We also have a weekly meeting for all of our patients on clinical trials where we together, it's called the Data Safety Monitoring Board, the DSMB, where we go through each patient and talk about toxicities and how they're doing and what we know about the trial or if there are any changes or amendments in that trial. And so that's kind of our piece. But the multidisciplinary team goes beyond that as well for a patient. So we do a clinic wrap-up in medical oncology at the end of the week where we include our palliative care physicians, our social workers. Many oncology clinics now have embedded supportive oncology centers that include nutritionists, physical therapists, social workers, psychologists. When you're spending, hopefully, years in getting therapy over time, needs change, right? There may be times where you're having more toxicity from therapy, where you do need attention to symptoms. There might be times in which there's less involvement, in which things are going well, and you have a clear pathway to that next appointment in several months. And so it's important to establish that whole team when you first meet, although it sounds overwhelming when we say, oh, we want to introduce you to palliative care, we want you to meet, you know, the 4 people that may be thinking about you. You're not going to see all of those people all of the time, but it's important to understand that you've got this entire universe of people that are watching and there to help you.
Michelle, anybody online with any comments or questions?
So someone's asking, should my kids get checked for lung cancer because their mother has EGFR adenocarcinoma?
I would say currently.
Okay. Should your children get checked for lung cancer if they have EGFR mutation?
If only one
person. One person of the lung, correct.
So I think the weight of the evidence suggests that probably a single case doesn't warrant really investigation into family history. There are some families in which multiple members have lung cancer, and we can see similar mutations within generations or between sisters or cousins. And for those, as Dr. Donington was saying, having a detailed discussion about other risk factors and resources that are available might guide sort of a baseline scan and testing, with the idea that if your children are young, we're looking at decades of some kind of surveillance, and that science will catch up. So right now we say usually if there's a single case, no, but that's a really soft no. I mean, the world is changing, and what we're able to do is changing. How we're able to detect cancers is changing. So.
Okay, I'm going to ask you a question now that I put you on the spot. So I'm a third generation on both sides of my family, and I'm the only one who has survived. And when something was first found on my lungs, I was 35. And that was, I'm almost 10 years, so that was 13 years ago. Well, my oldest at the time was very young. He's about to turn 22. In the real, with every other cancer, they always say your child, you should be screened 10 years younger than when something was first found on your parents. So and this is something I haven't really discussed, and I haven't discussed with my kids, but I have one that's about to be, in a couple of years, 25, where 10 years ago I thought, oh, it's a decade away. I bet there'll be a biomarker that'll be easier.
Right. Still holding my breath, right?
You don't have, but you don't have to answer, but just
but
something
I think it's difficult, and I remember very clearly when I turned 42 and sort of was older than when my father had pancreas cancer, and then I was like, finally, okay, it's all right. So that idea is certainly there. I think it's hard,
and it's probably a conversation you need to have with your son. He's been living with lung cancer through you for a long time. Does he want to know? Does he want to go through it? I don't know. Right. It's you're very knowledgeable, so it would make it a very interesting conversation.
Yeah, with him, the other three would be a little different, but he would be, very interesting.
The problem is all guidelines inherently fail at the individual, right? Guidelines are meant to be population-based. Right. They're statistically based. We're trying to cut through a swath of people to get the most benefit, and that clearly means we're going to miss people, and it's frustrating. And you're at an excellent point there. Now, to just put the same devil's advocate kind of question back at. So when he gets a CAT scan and it has a 1 centimeter nodule, granted it's well-rounded, and we live in the histoblasto belt. Now, given your history, he's clearly concerned, but he undergoes an unnecessary resection for a benign disorder because we looked for it. Right. So for all the good, there's the potential for bad. Now, I'm a big believer that every guideline clearly states right at the beginning, patient discussion, patient preference always. I have patients who I say we should watch and wait this, and they say that's not acceptable to me. I want it out, and I say my advice is against it, and then depending on the scenario, they might get it resected, and that's their preference. I give guidance, and we all do. She may say you should have surgery, and the patient says, I'm going to go find someone who says not to have surgery. Right. And if you look around, you'll find someone who will agree with you eventually. It might be your sixth opinion.
Well, right.
I will say one thing, depending on the age of the children. Lung cancer screening is clearly important. Let's start with some of the pure basics. Depending on this person's family. If they're a smoker, they have to quit, period, done. And if they're around a lot of secondhand smoke, thankfully that's harder to do these days in this country, but it's still very much available in certain places. I'm looking at you, Northwest Indiana. Then you need to get away from the secondhand smoke exposure. Big problem of radon within Illinois, and a lot of us live in our basements. And if you live in your basement, you're potentially having significant radon exposure. It's an under-recognized etiology of lung cancer, especially in this state. Not as much in the Chicago area, but in the greater Illinois area. Do you work around asbestos? We always think of mesos with asbestos, but asbestos is a major risk factor for lung cancer. So start with the basics and easy stuff as opposed to just wondering about EGFR, and make sure this person's avoiding the obvious things. Now, they probably are, and that's great. Then it's the same discussion. But we'd be remiss if we weren't bringing up, for all the people that are online with us right now, where smoke has been a component of their life or still a component of their life. And that's all smoke, by the way. As far as the lungs are concerned, smoke is smoke is smoke. We don't yet know the definitive level of carcinogenesis with vaping, but I will tell you, your lungs are not designed to have a lot of junk go into them. There was a study years ago to look at inhaled insulin. Insulin, something your body makes. And guess what? higher rates of lung cancer in people who got inhaled insulin. Your lungs are not supposed to have things go into it except air.
Including marijuana?
Yeah, and very much including marijuana.
It's an
Because a lot of
cigarette.
teenagers
Smoke
think
is smoke
that
is smoke.
marijuana doesn't cause lung cancer, but
Right.
I always say it causes irritation. Irritation causes inflammation.
Smoke is smoke is smoke.
Right, the carcinogens in marijuana are pretty much the same carcinogens that are in cigarettes and tobacco. I mean, the reality is it's hard to smoke 33 marijuana cigarettes in a day.
However,
but they are unfiltered, so
however,
it's
there's
something
actually, so there is great data on this though, because even though the average cigarette smoker doesn't actually smoke down the entire length of a cigarette, if someone is smoking marijuana, every last drop is usually smoked, and on top of that, the way you smoke it, nobody smokes a cigarette going, and then holds their breath for a half an hour, right? And so there's a significant amount of alveolar surface contact. And so actually marijuana smoke, at least some data out of New Zealand shows that it's actually more dangerous for the development of COPD than cigarette smoke. Because there's that much higher level of exposure per smoke, if you will, as opposed to just a cigarette. Not that that's a good idea either. We're going to see. So here's the thing that's going to be interesting. From a public health perspective, the advent of legalized marijuana in the United States and certain states is going to be a fascinating experiment to watch from a public health perspective. Okay. And I'm going to sadly predict that about 10 years from now, we're going to see a massive spike in lung cancer in the greater Colorado area.
Well, and I think with the greater...
And for sure, COPD.
With the, what you brought up too, with the vaping and the Juuls and the e-cigarettes and
we just don't know enough about any of them.
No, but the kids think it's safe.
Yep. Yeah. Good marketing.
It's horrible.
Okay. All right, so any other questions?
Yeah, I have a question. I had a lung resection 4 years ago. And so I have a next door neighbor who had one 2 months before I did. She had a CT in April, and she was told now that she has 3A, it's back. So my question is, how long do you have? Like, I won't get another CT until next year. Is it apt to come back between now and next year? And if it does, how long do you have to treat it?
So the science of how we survey, which is what we call how we monitor people who we've treated for lung cancer and think we've cured, isn't so specific. There are some things we know though. Of the people who are going to recur after like a successful surgery for stage 1, about 80 to 85% of them will recur within the first 4 years. So if they're going to recur, it tends to happen early. And actually we think most are kind of within like right around 2 to 3 years. So in that time period, we tend to scan people very frequently. And about half of the recurrences we find on scans, and about half we find just by talking to people. Oh, you have headaches. Oh, your hip hurts. Oh, something new is going on. Now that we have good treatments, I think we become a little more aggressive and in tune about surveillance, because we do have good ways to treat people if they recur. I will tell you that most people who get a second cancer get a very early stage cancer. So that's kind of after 4 or 5 years. What we're really looking for isn't really that your cured cancer is coming back, is that you may grow a new one, right? You had that original mutation that gave you one tumor, you could very easily get another. And so that's kind of what we're looking for when we say we're getting a scan each year. But the chance of the original tumor coming back after 4 or 5 years is becoming smaller and smaller.
I wasn't thinking the original tumor as much the original cancer. I guess that's one and the same.
The original cancer. Once it's been 4 to 5 years, we think most of our patients are cured.
Okay. What about, how long do you have from when you find out or you have symptoms before you do something? Because I'm trying to talk her into going to.
The sooner is always better. I do sometimes, tell our patients we try to get a time frame. There have been some studies that showed the sooner you go to treatment, the better your outcomes are. There's a lot of complicated things about why someone's treatment may be delayed, but sooner is better, and I always tell my patients who come in and are trying to fit surgery into the rest of their lives that we should really be thinking about getting treatment started within a month or so, and after that, you're dragging your feet.
And she said she's doing immunotherapy because she has genetic markers? I thought this was not genetic.
Should I pass it to Dr. Patel?
So
That's a great question.
Yeah.
Right. So
All my questions are great.
They are.
Indeed, but that one in particular.
So when people talk about markers, they talk about after the tumor has been diagnosed and examined, we do a test called PD-L1, which is looking at.
What is it called?
So it's PD-L1. It's a marker for immunotherapy, and it is a protein that lives on cancer cells and is the target of some of the new drugs like Keytruda and Opdivo that you see advertised. And so that's immunotherapy. The other part are the genetic markers, and those are the mutations that are in the tumor that we talked about a little bit, I think, before you were here, EGFR and ALK and BRAF, and that's within the genetic makeup, so within the tumor. The other ones are proteins that are expressed on the tumor.
So lung cancer is very genetic now.
There's the genetics that you inherit from your mom and dad that determine who you are as a person, etc. But then the individual tumor has its own profile genetically. Each person's tumor is as different as each person. It's also frequently why, at the very beginning, when people were introducing themselves, I don't think I heard a single person have the same therapy at all, or combo, and that's actually a fantastic thing, because 15 years ago, everybody here in the room would have all gotten a one-size-fits-all approach to their lung cancer. And now, based on the individual differences of the tumor, they're getting very individualized therapy, which is changing weekly as better and better and more science drives newer discoveries. And then that's the need for more and more tissue to test for these things. That's, I think, probably the equally important thing for anyone who's online who's been told at the moment that there's no other options for you. That may sadly be true, but I think it's very unlikely that it's true. You need to definitely go to a major cancer research center, because there may not be a FDA-approved therapy for you, but I guarantee you places like ours are busy doing research on several other new options that may or may not be a candidate for. If someone tells you we don't have any other therapies for you, it needs to be someone like Dr. Patel. If she says she has no other tricks up her sleeve, then sadly it's true. Until she says that, though, it's never true. No, it's true.
What about, there's two different genetics, the cancer or molecule genetic, and then the personal from your parents' genetics.
So some of the genetics of cancer are things that happened over time. So you can get mutations, that the genes you were born with change. They get damaged, things happen over time, and that's one way that cancers grow, is that they develop mutations. And those are things that you weren't necessarily born with, but that happen, and the combination of the genes you're born with and then the changes to those genes that develop over time is what allows cancers to grow.
So the fact that my brother was diagnosed 2 months before I was, had the same cancer, the same size, he was a smoker, 3 packs a day. But then I have another brother and sister, and I have kids. Should they all be tested or not?
We've talked about that it's complicated, that we don't, no, it's okay, because it's not, I don't think we give good answers. It's a complicated answer that we don't understand all the genetics of cancer and of tumors, and especially lung cancer is not one that has been well teased out. There is definitely some risks that people are born with, whether it's their ability, certain genes that are turned off that help fight cancers or detect cancers as they start growing or not. We don't fully understand that. But again, large cancer centers have genetic counselors and cancer-specific counselors to kind of help with that discussion, because it's hard.
And, you know, we talked about that the mutations that drive these tumors can occur spontaneously. You don't have to have a single risk factor, not even necessarily a family risk factor. But one of the things that helps drive all mutations are the obvious causes of mutations, things like cigarette smoke. So though lung cancer very much can occur in non-smokers, and that's one of the things we've been talking about tonight. But anybody who is still a smoker or is thinking about smoking absolutely must quit, because smoking's main purpose is to increase the rate at which you have mutations, which increases the rate of a cancer developing. It can already happen without. Why are we trying to help it? And spending money to do so.
Okay, here, Kim.
I wanted to hear all the options. Oh, you know, not all the options, but I wanted to hear a discussion about the C797S mutation and just what's going on with that.
So, so what we're talking about is EGFR mutations generally come from, there's two common mutations and a bunch of uncommon mutations, but most of those are sort of the founder mutations and mutations that people have when their cancer is diagnosed. And over the years, we have 5 drugs now, dacomitinib as well, right, that have been approved for patients as initial therapy. So that's gefitinib, erlotinib, afatinib, osimertinib, and now dacomitinib. And all of those drugs are effective in patients who have these initial mutations and cause tumor shrinkage and deep responses. The problem with, and we're all excited when you have it, because tumors shrink by 90% sometimes. Like, we see these phenomenal responses. But the issue with targeted therapies are that often tumors develop new mutations and make these targeted therapies less effective. So we know with the older generation drugs, like gefitinib, erlotinib, afatinib, that fairly predictably people would develop mutations. And about half of people developed a mutation called T790, and that made these drugs ineffective or wouldn't let it bind very well. And so we were very excited when Tagrisso became approved and could overcome that. There was a lot of effort with another drug that we were testing, ruxolitinib, that we thought could do that, that came with some side effects. But in any case, Tagrisso could overcome that. And then Tagrisso subsequently showed that even if we did it in the frontline setting, it was better than many of these other agents. We're just now learning what Tagrisso resistance looks like. We've learned that unlike first generation drugs, where we could say half of people develop T790 and there's a smattering of others, the mutations that we see with Tagrisso are much more varied. So we see 797, which is also a gatekeeper mutation. So that means, and it's kind of crazy to think about the stepwise progression of this, that you have a single mutation, a single base pair that's causing your cancer to grow. You develop one new mutation that makes that drug less effective, and then a third mutation that makes the second drug less effective. But we can see sort of this clonal evolution. And we can test it often in the blood, sometimes from the tumor tissue, and our techniques are getting better. But 797 is so far difficult. There's 2 kinds of 797 as well, which makes it even more complicated. One makes Tagrisso less effective and sort of all of the available FDA-approved options not work. Another one actually changes the binding site so that drugs are resensitized to Tarceva, which is kind of crazy as well. But it's, again, a single base pair, and that one's very uncommon, but it's certainly been described. So 797 is now sort of our holy grail, but we also know that patients who develop resistance to Tagrisso develop things like MET amplification. So that's a gene that we've seen across a lot of tumor types. We talk about MET exon 14 mutations in lung cancer and across a variety of tumors that has a lot of activity. But what we're really talking about are gene numbers increasing and causing the cancer to grow as a bypass track. We see HER2 mutations, we see translocations, so again, that chromosome flip-flop. All of those are less common, but certainly we are eagerly testing multiple ways to treat all of these permutations, and it requires sort of testing one after another. For 797, again, because it's an EGFR, it's just within the EGFR gene, it should be that we can overcome resistance by developing a compound that may be able to fit stereotactically into that binding groove. Certainly, we were talking a little bit before at World Lung, in which 12,000 people dedicated to lung cancer research got together in Toronto. There was some exciting data. There's some bispecific antibodies that look that they can overcome. There's some early cell line work with a couple of the TKIs that are a little bit dirtier that overcome a lot of EGFR resistance. And so I think there are a number of molecules that look promising. Very likely it's going to be something we call an antibody, which is most effective, and that binds to the outside of the tumor cell rather than going into the tyrosine kinase inside the cell that most of the oral drugs do. So they're probably infusional. Drugs like poziotinib and TAK-788, which are the Takeda drugs. There's another drug called brigatinib. There may be some potential there, and certainly they're overcoming different EGFR mutations that were less well recognized until we started really doing deep sequencing like exon 20s. And so I think all of these drugs are promising. Right now, I don't think there's a clear winner. These are early, we're just finding this mutational profile, and so there are a number of clinical trials. I think the common pathway for many patients right now is chemotherapy because it's effective. But my sense is that we'll have all of these tools available, and primarily I think the antibodies make sense. When we didn't know how to overcome T790, for example, we used afatinib and an antibody called cetuximab, and so that was a tyrosine kinase as well as the infusion. Again, any way to sort of saturate EGFR and the extracellular sort of binding domain, so outside the cell with the antibody and inside with the tyrosine kinase inhibitor, because all of the drugs work. It's not like they don't stop binding completely. They have some efficacy, but they're not as potent as they were initially. So long answer, but things are happening. Chemotherapy works. Probably still, immunotherapy's captured all of our imaginations, but certainly I think we have a long way to go in really selecting patients who'd benefit the most from immunotherapy and combining immunotherapies with things like radiation and chemotherapy to make them more effective. Likely when you have one particular mutation, it's still probably going to be targeted therapy or chemotherapy that's a little bit more effective.
From the non-oncologist perspective, probably the most exciting thing is that a couple years back I would be giving a lecture on lung cancer to a bunch of students or whatever, and we'd have a pie chart of actionable mutations for adenocarcinoma, and it was EGFR, and it was like a little wedge, and most of the pie chart was red, meaning we didn't know squat. And I think we all freely admit we don't all update our slides for every talk we give. If you don't update that slide, then it's pretty obvious how far behind you are, because now the amount of wedge that we don't know just keeps shrinking. And just hearing all that, so even just looking back, the amount of research and development that had historically gone on in lung cancer was a drop in the bucket. And now it's a waterfall, and it's fantastic. And it's only great for those of us who are in this field and for the patients, because we're having more and more options. And I think that comes back to research initiatives, that comes back to patient registries, that comes back to blood banking, tissue banking. Every success that we have today is on the shoulders of the people who volunteered before. And it's on the people with the physicians who were willing to try something different, and with the patients who were willing to volunteer on some things that may have sounded crazy at first. First chemotherapy sounded pretty darn crazy, and here we are. And so, that spirit of giving forward is the only way we're going to keep making advances here, so that this becomes a disease that we can either completely cure or at a minimum keep it at bay and just have it be one of those chronic things like diabetes. And either way, that's a win. So.
And I'll put a plug in for our cancer registry. So if you've not signed up for that, if you go to our website, it will have information on our lung cancer registry where you submit your data, and that will help. We don't know what we don't know. So it's a good way to give freely. It's not a clinical trial to sign a bunch of paperwork, but you know, there is the confidentiality there that you share your data. Then you can see other de-identified data as well. But I want to change gears right quick for just a minute because we had someone want to talk about small cell for just a minute, and with the new immunotherapy recommendations, and even bring in maybe a little bit of tumor mutation burden testing that may need to be done with that.
Sure, so small cell is a tough cancer. It's probably less than 15% of all lung cancer in the United States, and it may be decreasing in the United States, but it's still a huge swath of patients. It's the 6th leading cause of cancer death, and it's probably increasing in low resource countries, primarily because of the smoking behaviors. Most people with small cell lung cancer have a lot of carcinogen exposure. So 97% of people with small cell lung cancer have been smokers. And so their tumors often carry a myriad of mutations and are sort of hot and bothered, so we speak. The problem with small cell lung cancer is that metastasizes early. Although at first it sort of melts away with chemotherapy, it becomes resistant pretty quickly. And we've had the same therapy for 30 years, carboplatin and etoposide or cisplatin and etoposide, and that didn't change very much. We made small incremental benefits with adding radiation to some patients. The second FDA-approved drug was called topotecan, and that's really about it. But certainly because of the tremendous toll, we've been wanting to do a lot of research. The research in small cell lung cancer, I'd say, has not been as gratifying for a couple of reasons. One is that we don't have good amounts of tissue from small cell. So most people who present have a lot of disease. Very few people ever go to surgery, so we end up getting small biopsies on these patients. And so we don't have extra tissue to do a lot of research analysis. It's also been really tough to have good models. So one way we test drugs is xenograft models, in which we inject tumors into mice and then try different drugs and understand how tumor microenvironments work. And so that's never really panned out. So we haven't really had a lot of lab data. We've tried empirically a lot of different drugs in patients and have some targets that I think are more exciting than they've ever been. Things like have extensively studied notch signaling. So there's a protein called DLL3, delta-like ligand 3, which is expressed on small cell lung cancers and not on other tumors. And there are some antibodies that are being developed that look promising and cause responses in a group of patients. They're working on formulation. There are some other targets, such as PARP inhibitors, which can block DNA repair mechanisms. We might be able to measure how effective they are with certain mutational markers like Schlafen. But I think what's really changed the field and what's really been the first leap forward is the advent of immunotherapy for small cell lung cancer. So certainly as single drugs, we know that pembrolizumab and nivolumab both have efficacy. Nivolumab's been approved by the FDA in the 3rd line setting for small cell lung cancer because it causes cancers to shrink, again, in a small number of patients, in less than 15% of patients, but that shrinkage lasts for a long time. It's durable, we call it, without a lot of toxicities. What's really changed a couple of months ago was the introduction of chemotherapy with immunotherapy. And so a drug called atezolizumab was combined to this backbone of chemotherapy. And it didn't improve disease control rates or shrinkage rates because these chemotherapies are so effective, but what it really improved was survival at 12 months and at 18 months. And so we see a significant improvement of about 15 or 20%. And that's the first positive trial we've had. It's not yet FDA approved, but it likely will be soon. I mean, it's a phase 3 registration trial. And most of us now think that because this drug is available off-label, so it's approved in lung cancer and bladder cancer, that most of us think that if you're diagnosed with small cell lung cancer, you should get chemotherapy and immunotherapy as your first treatment. that leaves a lot of questions about what comes next, because we kind of felt that we could do immunotherapy after chemotherapy. Maybe immunotherapy was more effective when there was less tumor burden. That means you wouldn't need as many white blood cells to fight all of your tumor. So much of what we do now with immunotherapy is sort of cytoreduction or tumor shrinkage and then give immunotherapy. There are questions about if you develop resistance, can you add another immunotherapy to see a response? So that is sort of the unanswered question. In that trial, we don't have any patient selection. And that's primarily because traditionally with small cell lung cancer, we got a tiny biopsy. We said you have small cell lung cancer and then just move forward. In one of the trials that BMS ran with the combination of nivolumab and ipilimumab, they were able to get bigger chunks of tissue, and I think in about 40% of patients they were able to do genomic testing to test tumor mutation burden. And they found that patients with the highest levels of tumor mutation burden, so over 10, were much more likely to have a good response to immunotherapy. So going from a selection of maybe like 10 or 15% to one in greater than half of patients would benefit. It certainly changed how we're approaching this cancer. I don't think that clinically, we're recommending that patients off of trial get tumor mutation burden testing for small cell lung cancer, but with the publication of these small studies, certainly I think that's going to be tested prospectively, so we'll have better guidelines. But very likely this story about tumor mutation burden is happening in every tumor. Yep. So it's not just about which cancer you have, it's do we see that in your bladder cancer, do we see it in your lung cancer, can it predict response in your gastric cancer? And so in many ways we're learning from different tumor types, and it's the fundamental biology rather than sort of what we call the phenotype, so what your patient looks like and what the tumor looks like under the microscope.
So I have a quick question about that. With the abscopal effect not being so anecdotal anymore, there's stuff that is there more excitement towards trials with immunotherapy or checkpoint inhibitors and radiation?
Yes.
So there is a lot more going on.
Right. So there is just a really
in lung cancer.
In lung cancer.
I know in other cancers there has been, but I just read some study that came out today.
Yeah, pretty cool.
Yeah.
So, so the study is essentially treating lung cancer with radiation and then giving a CTLA-4 inhibitor, which by itself, that's ipilimumab, doesn't have high response rates, like less than 5%. But with radiation, the response rate jumps 8-fold, and it's quite impressive. We are really excited. Livia and I have been spending the past year now
every Monday
every Monday and Wednesday talking about our trial. But our frontline trial at University of Chicago is a combination of radiation and immunotherapy. And what we're trying to understand is what radiation really does to immunotherapy and does to a tumor. So this is where I call Kyle all the time. Mm-hmm. I do a tumor biopsy before we start therapy, and we radiate whatever he biopsies, then we give radiation and immunotherapy, and then we biopsy the tumor again. And what we're seeing is that radiation probably changes the genetic profile of the tumor and might make immunotherapy more effective. So more and more we're pretty excited about it, Liv.
Yeah,
what would you say?
And more side effects too that we are seeing and we are learning.
Right. So it's a lot of treatment. And again, for a patient to volunteer for 2 biopsies for this phase 1 trial, we're going to treat this and give you immunotherapy. It's a lot. It's a lot.
It is done under general anesthesia, though. You're very comfortable. Your throat's sore for a day or two. You go home afterwards.
So let's all talk about sleep. It's getting late here. We do have to wrap it up, and I want to thank you all so much.
Oh, thank you.
You all have been so engaging and informative to everyone here and everyone online. So thank you of giving your time. And I do have to read a list of thank yous because without them, this would not be possible. Yep. Besides the University of Chicago, thank you all so much. AbbVie, Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Celgene, Genentech, Lilly Oncology, Medtronic, Merck, Novartis, Takeda Oncology, Yahoo Employee Foundation, Beverly Boy Productions, our catering team, and most importantly, our physicians and especially patients and caregivers. And just thank you all so much. And just remember, it's Lung Cancer Awareness Month. You can go to our webpage and find more information about thriving with lung cancer. And tune in next Tuesday for our living room back in San Carlos, California, that will be available online again. The topic is going to be on tumor boards, so it'll be very informative. It's at 5:30 Pacific time, which is 7:30 Central time, 8:30 Eastern time. And we hope that everyone will join us again next week. So thank you again.
Thank you.
Thank you.